We've got about just over half an hour. Sorry to come a little bit late because I know this is really important to us people. And Leonard has emailed me hundreds of questions which are on the slides.
I've already had one ACDF infusion, but the last 6 months my wife is not deteriorated. So what is the percentage of the need of another ACDF or anything, or how do you go about it? Because is it all back to square one, going to your GP, giving him the symptoms, and then he refers you back to a neurosurgeon, which either in Peterborough, the nearest one they said is Cambridge. Do I have to go through all that again? And what is the percentage of people that have had one needing another one?
So we don't have enough data to say how many people who requires second surgery, but there is, it's definitely something that must be considered. The way that myelopathy is treated and followed up in Toronto at this point is that patients are being brought back to clinic on an annual basis for many years, not only for the first year after the operation. And that's because they found that that you can have recurrence. You can have another level can wear out, and the only way to detect this is by doing another MRI scan. And also, they even do MRI scans if you don't improve after surgery, because you should expect a certain amount of improvements. So this country here, this is not very established, and we need to change that.
I think the mechanism, unfortunately, although he agreed to see you again, it just requires that process. This is a process. They can't agree to see you until the GP said the next day.
Yeah.
Okay, my last question, and I think this was put forward by quite a few of our members, and I promise I'll shut up after this. The sort of, you did quote some figures for us earlier on about a very small percentage of post-operative patients seeing worse. But my question is, if my spine is degenerating now at 54, what are my chances of this op being successful in halting that degeneration? Am I going to be later on in my life, hopefully, still with us, but is this going to recur as in Paul's case? I know you're not about a crystal ball. I'm talking about professionally. What have you seen as statistics?
So again, the case series that we have is now 2-year, 3-year follow-up. We see.
I'm thinking more in the future.
Yeah. So we see that there should, if it's correctly done, you improve, and as a ballpark figure, you get about half of your function back that you've lost. But that's on the MJOA scale, which is a very skewed scale. Will it hold the progression of your degeneration? It should hold the spinal cord degeneration. Okay, it won't hold the cervical spine, so the bony and ligamentous degeneration at the levels above and below. So you're at risk of having the same disease again at a different level.
Okay, so once you've had this weakness, this problem in the spine, mine is C5, C6.
Yes.
So it's quite likely that it could start occurring in C3,
it is possible.
C4.
It depends a bit on how it manifests itself. If you've got, say, OPLL, for example, and this is multi-level disease anyway. If you have an operation from the back with the fusion, then it's less likely to recur because it's a much bigger operation. If you go in from the front at a single or second level, then obviously you have the risk of wear out at another level in the future.
Potential for
and that's why I think individuals with CSM should not be discharged. They should be seen once a year.